When a person receives a cancer diagnosis that could have been made months or years earlier, the conversation that follows almost always contains a version of the same sentence. I thought it was something else. I thought it would go away. I did not want to make a fuss about something that might be nothing. And the symptom they are describing, the one they waited on, dismissed, or attributed to something less alarming, was often not subtle. It was a change in their body that they noticed, that persisted, and that they chose to explain away rather than act on, because the explanation was more comfortable than the alternative. I want to have a direct conversation today about the cancer warning symptoms that demand action, and that most often get the explanation away treatment, not because the people experiencing them are careless or unintelligent, but because the medical system communicates these signals poorly, because the normal for me rationalization is powerful, because most of these symptoms do have benign explanations, and the statistical odds in any given case do favor something less serious, and because the discomfort of a medical appointment and the anxiety of an investigation often feel worse, in the moment, than the uncertainty of waiting. I want to change the calculus of that waiting decision today. Because the difference between acting on a cancer warning symptom at 6 weeks and acting on it at 6 months is, in several of the cancers I am going to discuss, the difference between early-stage disease with excellent treatment options and advanced disease with significantly narrower ones. And that gap, measured in weeks and months rather than years, is the window that early recognition creates. Before anything else, what I share in this video is educational information only. It is not medical advice. Not every symptom I describe indicates cancer. Most of the time they do not. But all of them, when they meet the specific criteria of persistence, change from baseline, or accompaniment by other signals, warrant prompt medical evaluation rather than watchful waiting. A will be specific about when to see your doctor within days versus weeks versus urgently, and those distinctions matter. I am Dr. Andrew Carter, and I have spent 15 years working exclusively with adults over 60. The age group I work with carries the highest cancer incidence of any demographic, and the clinical reality I encounter most often is not late diagnosis from lack of screening programs. It is late diagnosis from symptoms that were present early, that were recognized by the person, and that were managed with a combination of self-explanation and delayed action that allowed the disease months of uninterrupted progression. This video is for that gap. If this is your first time on this channel, subscribe right now because every week I bring you specific, grounded information about what your body is communicating after 60, and this video may prompt the conversation that changes an outcome. Let me start with the framework doctors use to assess cancer risk from symptoms, because it makes every individual symptom more understandable. Clinical cancer risk assessment of symptoms uses 3 dimensions simultaneously. The first is character. What specifically is the symptom, and does it match the profile associated with early cancer in a specific anatomical location? The second is duration. How long has it been present, and is it persisting or resolving? Symptoms that have been consistently present for more than 4 weeks without resolution or clear benign explanation are at a different clinical threshold than symptoms present for a few days. The third is combination. Is the symptom occurring alone or alongside other signals that individually might be explainable but together form a pattern that raises the prior probability of a malignant cause? The 2-week wait rule, used in the UK National Health Service, is a concrete example of this threshold thinking. When a patient presents with a symptom that meets specific criteria for possible cancer, they are referred for investigation within 2 weeks rather than waiting for a standard appointment queue. The criteria are based on the duration and character of symptoms, not on a confirmed diagnosis, because the confirmation requires the investigation. The 2-week threshold represents the window in which the benefit of acting on a possible cancer signal clearly outweighs the inconvenience and anxiety of investigating something that turns out to be benign. Every symptom I describe today should be read through this lens: persistent, changed from baseline, and potentially combined with other signals. Individual, brief, and explicable symptoms rarely meet the threshold. Persistent, unexplained, and combined symptoms do. The first cancer symptom category that demands action is unexplained. Unintentional weight loss, defined as losing 5% or more of body weight over 6 to 12 months without any change in diet, exercise, or deliberate effort. Unintentional weight loss is one of the most consistent, non-specific early signals of systemic cancer, across multiple cancer types. The mechanism operates through several pathways simultaneously. Cancer cells consume glucose preferentially and at high rates. Many cancers produce cytokines including tumor necrosis factor and interleukin-6 that directly suppress appetite and increase the metabolic rate, a syndrome called cancer cachexia. And the immune response to a developing cancer activates systemic inflammation that increases the catabolic burden on muscle and fat stores. The cancers most associated with early unintentional weight loss include pancreatic cancer, gastric cancer, lung cancer, lymphoma, and renal cell carcinoma. In adults over 60, this symptom, in the absence of another clear explanation, should prompt a targeted evaluation, including blood count, inflammatory markers, kidney and liver function, and depending on the risk profile, specific cancer-directed imaging. The key qualifier is unintentional and unexplained. A person who has been eating less because of stress or illness does not meet this threshold in the same way as a person whose appetite is unchanged and whose weight is nonetheless falling. The weight loss that happens without a change in behavior is the signal. The weight loss that accompanies an obvious behavioral or situational explanation is not the same clinical concern. If you have lost more than 5% of your body weight over the past 6 months without deliberately trying to, please bring that to your doctor within 2 weeks, specifically framed as unexplained weight loss rather than as I think I have been eating less or my appetite has been poor. The specific framing prompts the investigation pathway appropriate to the symptom. Type in the comments right now if you have ever lost weight unexpectedly and either not mentioned it to a doctor or been told it was stress or anxiety without investigation. Because the frequency of that pattern in those comments will tell me something important about how often this signal is underweighted in standard care. The second cancer symptom category is persistent change in bowel habit, and this encompasses 3 specific changes that each warrant different levels of urgency. Persistent, looser, or more frequent stools that have been present for more than 4 weeks, without a clear dietary or infectious explanation warrant evaluation for colorectal cancer. Colorectal cancer is the second most common cause of cancer death in adults over 60 in most developed countries, and the change in bowel habit, specifically toward looser or more frequent movements, is one of its most consistent early symptoms, particularly for left-sided colon and rectal cancers. A persistent change in any direction, more frequent, less frequent, looser, harder, narrower than usual, that has been present for more than 4 weeks deserves a colonoscopy evaluation. Blood in the stool, whether bright red or dark and tarry, warrants evaluation within days to 1 week rather than weeks. Bright red blood may reflect hemorrhoids, which are common and benign, but it may reflect rectal or sigmoid cancer, and the two cannot be reliably distinguished by the character of the bleeding alone. Dark or tarry stool, which reflects blood that has been partially digested during transit from higher in the bowel, warrants same-day evaluation as a possible acute upper gastrointestinal bleed. The important message here is, do not diagnose yourself with hemorrhoids. Many people in their 60s have hemorrhoids. Many people with rectal bleeding have hemorrhoids, but the bleeding is not attributable to hemorrhoids until hemorrhoids have been confirmed as the source by direct visualization, and a person who self-diagnoses and waits without confirmation is at risk of delaying the diagnosis of something that shares the same symptom. The third bowel change is a persistent sense of incomplete evacuation after a bowel movement, a feeling that the bowel has not fully emptied, that is new, and has been consistently present for more than 4 weeks. This symptom, which is often attributed to incomplete emptying from constipation or IBS, is a known early symptom of rectal cancer and deserves evaluation in any adult over 60 without a prior diagnosis explaining it. And share this video right now with one person in your life over 60 who has been dismissing a change in their bowel habit because they assumed it was something they ate, or a temporary disruption. The 4-week threshold I described is the line between temporary and persistent, and they need to know where they stand. And if you are not yet subscribed to this channel, tap that button now and ring the bell. The third cancer symptom category is persistent cough, unexplained breathlessness, or coughing up blood. A cough that has been present for more than 3 weeks without a clear respiratory infection or allergic explanation warrants evaluation in any adult over 60. The 3-week threshold for persistent cough reflects clinical guidelines for lung cancer investigation because the early stage of lung cancer, most amenable to curative treatment, is frequently associated with no symptoms beyond a new persistent cough that the person attributes to a post-infectious cough, a dry air cough, or a throat problem. Coughing up blood, hemoptysis, warrants evaluation within days regardless of the amount. Even a small streak of blood in the sputum on a single occasion is not a symptom that can be safely attributed to throat irritation or coughing strain without investigation in an adult over 60. It may reflect throat or bronchial irritation. It may reflect lung cancer, pulmonary embolism, or a bronchial abnormality. The investigation that distinguishes these possibilities takes a chest X-ray and possibly a CT scan, not a wait-and-see approach. Unexplained breathlessness that is present at rest or with minimal exertion, and that is new and has not been attributed to a cardiac or respiratory diagnosis, warrants evaluation for both cardiac and pulmonary causes, including lung malignancy, pleural effusion, and mediastinal masses. Lung cancer is the most common cause of cancer death in adults over 60, and its poor prognosis relative to other cancers is substantially the result of late diagnosis. Most lung cancer deaths in this age group occur in people who first noticed a respiratory symptom many months before their diagnosis and attributed it to something else. The symptom was there. The evaluation was delayed. The window for curative treatment closed. One more symptom in the respiratory and head and neck category that is consistently underinvestigated: persistent hoarseness or a change in voice quality lasting more than 3 weeks without a clear viral explanation. Laryngeal cancer, which is highly treatable when caught early, presents almost always with hoarseness as its primary symptom. A recurrent laryngeal nerve compressed by a mediastinal mass, a lung apex tumor, or an enlarged lymph node chain can produce a characteristic voice change called vocal cord palsy that presents as persistent hoarseness. Any adult over 60 with hoarseness lasting more than 3 weeks warrants ENT evaluation within 2 weeks, not a wait-and-see approach. Before the breast section, I want to describe a symptom that is frequently attributed to aging or acid reflux, but that is one of the highest risk cancer warning signs in adults over 60: persistent difficulty swallowing, or dysphagia. Swallowing difficulty that is progressive, meaning it becomes harder to swallow solid food over weeks, and that then progresses to difficulty swallowing soft food or liquids, is the primary early symptom of esophageal cancer and of gastric cancer affecting the upper stomach. Esophageal cancer has one of the steepest prognosis gradients of any gastrointestinal malignancy. Caught early, curative surgery is possible. Caught late, it is among the most aggressive in the digestive tract. The specific pattern that should prompt urgent evaluation is progressive dysphagia, meaning increasing difficulty, not a fixed difficulty that has been stable. A person who has always had mild difficulty with large bites of dry food, unchanged over years, is not describing the same symptom as a person whose ability to swallow has been noticeably deteriorating over 6 to 8 weeks. The progression is the signal. Any dysphagia that has been getting worse over 4 to 8 weeks, any dysphagia associated with weight loss, and any dysphagia associated with pain on swallowing, called odonophagia, warrants urgent upper endoscopy evaluation rather than a trial of antacids. Antacids can treat the discomfort of reflux esophagitis. They cannot treat an obstructing lesion, and treating an obstructing lesion with antacids while waiting to see if it improves is the delay pattern that most consistently moves esophageal cancer from early to advanced stage. The fourth category is any new visible or palpable change in the breast or chest wall that is new and has been present for more than 2 to 4 weeks. In women, the changes that warrant prompt evaluation are a new lump anywhere in the breast or axilla, a change in the shape or contour of the breast, new skin dimpling or puckering of the breast skin, a new inversion of the nipple, any nipple discharge that is spontaneous, unilateral, or blood-stained, and persistent skin changes on the nipple or areola, including redness, scaling, or crusting. In men, breast cancer is less common but not rare, and the primary barrier to early diagnosis in men is the assumption that breast lumps are not a cancer concern in male patients. Any new lump in the male breast tissue warrants the same evaluation as it would in a woman, without the lower threshold assumption. These symptoms should be evaluated within 2 weeks, not after the next routine appointment. Within 2 weeks of noticing them. If you are not yet subscribed to this channel, tap that subscribe button now and ring the bell, because every week I come here to give you the specific information that makes the difference between acting early and acting too late. I want to tell you about a patient I will call Susan, 63 years old, retired accountant from Boston, Massachusetts. She had noticed a small lump in her left axilla, the armpit, about 3 months before she mentioned it to anyone. She had assumed it was a swollen lymph node from a cold she had had in the autumn, which had since resolved. When the lump was still there in February, she mentioned it casually to a friend, who told her to get it checked immediately. When she came to me, the lump had been present for approximately 4 months. It was firm, non-tender, and fixed to the surrounding tissue rather than mobile. These physical characteristics were concerning enough to trigger immediate evaluation. Imaging identified a 1.8 centimeter breast lesion on the same side that had not been present on her previous mammogram 2 years prior. The axillary lump was a lymph node with metastatic involvement from the breast lesion. The breast cancer was at an early metastatic stage. She received treatment. She is doing well, but she told me at that appointment, if I had waited another 3 months, would we have caught it at the same stage? Her oncologist told her, at the rate of progression we could infer from the size, probably not. The axillary involvement was early. Another 3 months might have been a different conversation. She told me, I thought swollen lymph nodes meant you had a cold. I told her, they do mean that most of the time. But the one that stays after the cold resolves, for 4 months, is the one that needs a different explanation. The fifth category covers several symptoms associated with cancers that are frequently diagnosed late, because their early presentations are nonspecific and overlap with many common conditions. Abdominal bloating or distension in women that is new, persistent, and not related to meals or bowel movement is one of the primary early symptoms of ovarian cancer, and one that is most often attributed to IBS, digestive sensitivity, or perimenopausal changes. Ovarian cancer has the worst prognosis of all gynecological cancers, specifically because it presents with nonspecific symptoms, and because those symptoms, persistent bloating, pelvic discomfort, early satiety, and urinary urgency, are so easily attributed to bowel or bladder causes rather than to a pelvic malignancy. Any of these symptoms that is new, persistent for more than 4 weeks, and present in a woman over 50, without a prior diagnosis explaining it, warrants evaluation, including pelvic examination and CA-125 tumor marker measurement. Blood in the urine, hematuria, warrants prompt evaluation within 1 week in any adult over 60. It may reflect a urinary tract infection, kidney stones, or benign prostatic disease, but it may reflect bladder cancer, renal cell carcinoma, or upper urinary tract malignancy. Bladder cancer and renal cancer are among the cancers whose earliest symptoms are frequently dismissed as something urological and routine. They are not always routine, and the investigation that distinguishes them from routine causes is a urine cytology and a cystoscopy or upper tract imaging, depending on the clinical picture. Painless hematuria, blood in the urine without the burning or urgency of a urinary infection, has a particularly high association with bladder cancer and should prompt urgent evaluation. Unexplained persistent fatigue that is present most days for 6 weeks or more, in the absence of an identified cause, can, when combined with other signals such as night sweats, recurrent infections, or painless lymph node enlargement, indicate a hematological malignancy including lymphoma or leukemia. We discussed fatigue in detail in the fatigue video on this channel, and the specific features that raise concern for malignancy are the association with night sweats that soak the bed sheets rather than simple warmth-related perspiration, the combination with any lymph node enlargement, and the combination with unexplained bruising or bleeding from gums or skin that reflects possible bone marrow involvement. New neurological symptoms in adults over 60, specifically new persistent headaches that are different in character from any previous headache, new visual changes that are persistent and not explained by a refractive change, new weakness or coordination difficulty on one side of the body, or new personality or cognitive changes warrant evaluation for primary brain tumor or cerebral metastasis. These symptoms are most often explained by non-malignant causes, but their persistence and their combination with each other raises the threshold for brain imaging that distinguishes reversible from malignant causes. The sixth category is skin changes, and the specific changes that demand urgent dermatological evaluation in adults over 60 are distinct from the general skin aging that is universal. A new or changing mole with any of the ABCDE features, asymmetry, border irregularity, color variation, diameter greater than 6 millimeters, or evolution meaning a change in any feature over weeks to months, warrants evaluation within 2 weeks. Melanoma has the steepest prognosis gradient of any common skin cancer relative to stage. Caught early, the prognosis is excellent. Caught late, it is among the most aggressive cancers in medicine. And the window between those two stages is visible on the skin surface. A skin lesion that bleeds spontaneously or with minimal trauma, that does not heal over 4 weeks or that is growing progressively should be evaluated rather than attributed to trauma or benign skin changes. Squamous cell carcinoma, which is more common in adults over 60 than melanoma but less publicized, typically presents as a firm, rough-textured growing lesion on sun-exposed skin that may crust, bleed, or ulcerate. It can metastasize if not treated, and its earlier stage management is significantly simpler than its later stage management. Here is the complete framework for deciding when to act on a symptom and how quickly. Same-day or emergency evaluation for any blood in the urine without the symptoms of a urinary infection, any coughing up of blood, any dark or tarry stool, any rectal bleeding alongside other symptoms such as weight loss or change in bowel habit, any new neurological symptom of sudden onset, and any symptom that is severe and represents a dramatic change from baseline. Also, any progressive difficulty swallowing that has worsened noticeably over the past 2 weeks alongside weight loss. Evaluation within 1 to 2 weeks for unexplained weight loss of 5% or more over 6 months, a new breast or axillary lump, a new or changing skin lesion, meeting the ABCDE criteria, persistent cough beyond 3 weeks, persistent bloating in women without a prior explanation, any blood in the urine even once, and any bowel change that is persistent and unexplained at 4 weeks. Evaluation within 1 month for persistent fatigue associated with night sweats, bruising, or lymph node enlargement, any symptom that has been present consistently for more than 4 weeks and does not have a confirmed benign explanation, and any symptom that is new for you, that has changed in character from any previous experience of the same type of symptom, and that your instinct is telling you is different. That last category, your instinct that something is different, deserves specific mention because it is real clinical information. The person who has had mild reflux for 20 years and notices that the reflux feels different this year, more frequent, less responsive to antacids, is carrying clinical information in that comparison. The person who has had occasional headaches for decades and notices that a current headache feels different, not positional, not responsive to the usual remedy, persistent, is carrying clinical information. The changed character of a familiar symptom is often the most sensitive, early signal the body produces, and it is the one most often rationalized away. 4 things to carry away. First, the 2 primary reasons cancer diagnoses arrive late are not the absence of symptoms, but the presence of symptoms that were noticed and not acted on. Unexplained weight loss, persistent bowel change, persistent cough, visible skin change, and new lumps are all symptoms that people notice, and that people frequently attribute to something less alarming. The 4-week threshold of persistence is the clinical signal that distinguishes benign and transient from persistent and worthy of investigation. Second, the combination of symptoms is more informative than any individual symptom. Fatigue alone is nonspecific. Fatigue with night sweats and lymph node enlargement is a hematological malignancy until proven otherwise. Abdominal bloating alone is common. Abdominal bloating with early satiety and urinary urgency in a woman over 50 is ovarian cancer until proven otherwise. The pattern is the diagnosis prompt, not the individual component. Third, the urgency of evaluation matters as much as whether to evaluate. Blood in the urine warrants an appointment this week. Unexplained weight loss warrants an appointment this month. A changing mole warrants an appointment this week. The specificity of the timeline I have given for each symptom category reflects the prognosis gradient of the cancers associated with delayed diagnosis in each case. Fourth, your right as a patient is to a specific answer to the question, what is causing this? Not a reassurance that it is probably nothing. A specific evaluation pathway that either identifies the cause or appropriately rules out the most serious possibilities. If you receive a non-specific reassurance for a symptom that meets the criteria I have described, asking specifically what investigation has been done to rule out a malignant cause is your right and your responsibility. Your body is communicating all the time. The early language of cancer is the same language as many common conditions, which is exactly why it is so often misread. What distinguishes it is persistence, combination, change from baseline, and the failure to respond to simple explanations or simple treatments. When a symptom meets those criteria, it has earned a medical evaluation regardless of how many benign explanations you can generate for it. Early detection changes outcomes in cancer more dramatically than in almost any other area of medicine. The window between detectable and advanced disease exists. Using that window requires recognizing the signals that define it, and acting on them before the window closes. Share this video with one person in your life over 60 who has been waiting on a persistent symptom they have been attributing to something less serious. You may be handing them the reason to make an appointment that changes the trajectory of what comes next. And subscribe to this channel because every week I come here with one purpose: to give you the information that makes the difference between a warning you recognize and one you miss. Aging does not take away your body's ability to recover. It simply reminds you to care for it the right way. Take care of yourself.